So I'll hold on a second. Give me, seem to be doubly connected. Can you hear me now?
Yep.
Yeah, that's better. Okay, so apologies for this. I'm going to be talking about new options for treatment-resistant depression, and I'm going to be talking about concepts, causes, and cures. So my disclosures are that I work for King's College London, and I am head of the Mood Disorders Service there, which sees a huge amount of treatment-resistant depression. In terms of the objectives of this talk, I'm going to review the concept of treatment-resistant depression. I'm going to outline causes and clinical aspects of treatment-resistant depression, and I'm going to talk about new treatments. So the first thing to say is that mental health disorders are extremely common. In terms of the burden of disease, we know that in the total number of people with depression in the world at any one time is about 300 million or more. And about 12% of these live in the European Union. Now, treatment-resistant depression as a concept really followed on from the concept of treatment resistance in other disorders, or indeed with other treatments, such as antibiotics. And the initial formulation of the concept was done by Michael Thays and John Rush in a 1997 paper. And this actually staged treatment-resistant depression in terms of the available treatments at that time. Stage 2 was failure of 2 antidepressants in serial treatment of a different class. So that would be an SSRI and a tricyclic. That concept has been modified to be the main formulation of treatment-resistant depression. And it's now a failure to respond to 2 treatments, albeit of the same class. The reason for this change is that Thays showed in studies after the initial formulation that there was no greater response with switching class than switching within class.
Professor,
switching between class was no better than switching within class.
Sorry for interrupting, Professor, but we cannot follow your slides because we just see your first slide. Is it possible to close one of your devices? I think you have 2 devices you are connecting from to the presentation.
Yeah, let me try.
Yes, please. Because we don't see and we cannot follow, we just hear your voice, so I'm so sorry.
Yeah, I know, it's very difficult because I can't move past the first slide for some reason. Let me go out and come back in again. I'll try to do this. Okay. Let me start my video. Right, I'm sorry about this. No, it's still not working. For some reason, it doesn't go beyond the first slide, which is strange.
Can you move with the slides without sharing it as a presenter's view? Not just.
Yeah, I can't move the slides at all. It's entirely frozen, which I don't know why. And it's frozen even in my. Let me go out. Exit full screen.
Hey, Professor, can you hear me?
Yes?
So, okay, let me explain you. You just need to share your screen, but you don't need to make full screen the presentation. Don't make it
Yeah,
full
but the
screen.
problem
Yeah.
is it's frozen. I can't actually, I'm
Okay.
going to try and close right, I've closed it. Okay, I'm still on with you. Let me go back in and find the slides and I'll reopen them.
Okay.
Right, here we go. Right.
Maybe you could mail them to the organizers so they show them?
Yeah, let's just try this first, Elias. Hopefully this will work. Yes, it's
Yeah.
working.
It works.
Okay, so these are my disclosures.
Perfect.
These are the objectives. This is the global context. I'm going to go quickly now. This is the epidemiology of depression, which I've been through before. This is treatment-resistant depression. So I will send the slides to the organizers so that participants can get them. This is the definition of treatment-resistant depression. And this is the STAR-D data. So this is the landmark study from Russian colleagues published over the course of the last 20 years. The overall cumulative remission rate after 4 treatment steps was 2/3, 67%. But with each treatment level, remission rate reduced, treatment intolerance rose, and relapse rate rose as well. So treatment-resistant depression is common and a big issue. So based on STAR-D, there are 2 pathways to treatment-resistant depression. So the first is the failure to respond to the treatment, and the second is the failure to retain or sustain the response. Current definitions of treatment-resistant depression focus exclusively on acute treatment trial failures without considering those that relapse. And this is unsatisfactory to the clinicians because current TRD definitions fail to capture a very large proportion of depressions for which numerous treatments fail. Now, treatment-resistant depression imposes an enormous burden, both in terms of suffering, disability, and also costs to society. So depression is one of the most debilitating, disabling diseases and causes a significant burden to both the individual and to society. WHO data suggests that depression causes 6% of the burden of all diseases in Europe in terms of disability-adjusted life years. And the annual costs, and these are from some time ago, about 10 years ago, but the annual costs of depression in Europe are estimated at 118 billion euros. And this comprises direct costs, the costs of treatment such as outpatient care, drug costs, hospitalization, but indirect costs due to lost economic productivity and increased morbidity and mortality, including excessive use of other healthcare resources. So in the United States, the total healthcare costs in the hospitalized treatment-resistant cohort are 4 times greater than those being treated for outpatient depression and 6.5 times greater than the comparison group. And you can see total depression-related costs in the hospitalized treatment-resistant cohort are 7.5 times greater than those in outpatients and 19 times the comparison group. So we can see this here with depression-related healthcare costs and general costs. If you are outpatient treatment-resistant, these are increased, but they're massively increased in the more severe who get hospitalized. Healthcare utilization increases with the degree of treatment resistance. You can see this here from paper from Russell with inpatient, outpatient pharmaceutical costs. The pharmaceutical costs are usually a relatively small fraction of the overall. You can see here something about 20% of the cost. Now, people reporting chronic depression have much lower employment rates than the rest of the population. Only about half of the population aged 25 to 64 who have chronic depression are in employment, compared to over 3/4 of those who do not have chronic depression. You can see this is with depression here, without depression. You can see across all these different countries here that there's this disparity, which is huge. And the lost income due to lower employment rate in people with depression is estimated at 176 billion euros per year across all the EU countries. Now, treatment-resistant depression is highly comorbid, both for psychiatric comorbidity and also physical ill health comorbidity. So you can see some of the common clinical psychiatric comorbidities, anxiety, panic, phobias, suicide risk, so on, but also common physical health problems such as cardiovascular disease, obesity, diabetes, and so on are also massively increased. Now, early adverse life events, childhood trauma, have a significant impact on patient response to antidepressant treatment. This is a major focus of our research in the Maudsley and King's, but this is an illustrative paper from Leanne Williams from the United States, just showing that patients who have experienced trauma in childhood were significantly less likely to react to treatment and achieve remission from depression. So you can see in terms of responders, no abuse, about 82%, but abuse, about 18%. And for remission, it was, again, similarly very different. In terms of the childhood trauma, our own work suggests that emotional trauma, emotional abuse or emotional neglect is the most powerfully damaging. There's also mortality increase. This is a study from Sweden, from Professor Eriksson's home country. And this showed, and it's a feature of Sweden, Finland, Denmark, and so on, that they have very good case registers and can do fantastic studies that other parts of the world can't do. But this study showed that mortality is higher in patients with treatment-resistant depression than in other patients with depression. The increased mortality in TRD is mainly attributed to external causes of death, so it's not mostly deaths by suicide. And young and physically fit patients have the highest relative mortality increase. So I won't dwell on this at great length because of the pressure of time, but just to say it was a well-conducted study which looked at about 120,000 patients aged between 18 and 69. So in total, 15,000 patients were classified with TRD, and the adjusted all-cause mortality was increased by about 35%. Mortality from external causes, including suicide and accidents, was markedly higher in TRD patients than in other depressed patients, whilst mortality from non-external causes was similar. So patients with TRD have an increased death rate compared to other depressed patients. Of course, this is increased compared to the general population. And rather worryingly, the relative mortality is highest amongst the young and physically healthy patients. Treatment-resistant depression and suicidality in general, 30% of patients with treatment-resistant depression attempt suicide at least once during their lifetime. However, it is unclear what the attempted and completed suicide rates are in TRD after initiating a treatment, and whether specific treatments increase or decrease these incidences. And this led to the paper that's quoted here, which did a systematic search through PubMed for studies of depressed patients who failed at least 2 antidepressants and were followed for 3 months, and the results are shown here. So you can see that in terms of treatment-resistant depression and suicidality, these are the different treatments, surgical treatments, CBT, psychological treatments, deep brain stimulation, ECT, ketamine, and so on, that all of them have an effect on the rate of suicidality. So of these, 30 studies investigated suicidality in 32 TRD samples undergoing deep brain stimulation, vagal nerve stimulation, ECT, treatment as usual, capsulotomy, cognitive behavior therapy, ketamine, and epidural cortical stimulation. The overall incidence of completed suicides was 0.47 per 100 patient years and of attempted suicides, 4.66 per 100 patient years. And no differences were found in incidence following DBS, VNS, or ECT. So the completed and attempted suicide incidences are high, but these incidents do not differ between the three end-of-the-line treatments, DBS, VNS, or ECT. So clinical trials should consider suicidality as an explicit outcome measure, and indeed that was done in the recent S-ketamine studies. Now I'm going to go through TRD staging models very quickly because I've got quite a lot to cover. This is the phase and rush model that I talked about from the 1990s, and really stage 2 is what has become the standard definition of treatment-resistant depression. But the change is that it doesn't need to be a distinctly different class. So it could be SSRI to SSRI, because we've learned from STAR-D that you don't need to switch class. This was developed as a guideline for psychiatrists. It's easy to use. It does have an assumption that certain antidepressants are more effective than others, and I think that's probably true. And augmentation and combination strategies were not really considered. We've also got the Maudsley staging model done by my colleagues, Professor Tony Clear and others. This is a much more sophisticated way of capturing treatment-resistant depression. It includes the duration of the episode, the severity, the number of failed treatments. Does not yet include psychosocial stressors, functional impairment, or comorbidities. But Abi Fukuda and Tony Clear and others have validated this model through a prospective follow-up, showing a significant association with the persistence of depressive disorder. And lastly, this is a relatively recent work from North America from people I've published with, Charles Conway, Mark George, and Harold Sakan. I've published with Charles and Harold. And this was towards an evidence-based operational definition of treatment-resistant depression. This was an attempt to draw together the field. And you can see they looked at the STAR-D data. Remember, in STAR-D, you have treatment with citalopram at level 1. Then level 2 is these different antidepressant options. But level 3, you can see there's a drop-off. And Conway and colleagues argue that this is an empirical justification of the old phase and rush failure of 2 treatments. And I think there's some credence to that argument. Okay. So conclusions in terms of staging. The proposed models give guidance for defining TRD, but have important limitations in terms of validity. Clinical use remains limited, and they've been used in very few clinical trials. Really, the only medication that's gone through an explicit series of clinical trials for registration as a treatment for treatment-resistant depression is nasal S-ketamine. So future prospective research should result in a revised TRD definition, but a standardized TRD definition would include use of evidence-based novel treatments for patients with TRD. Take-home messages: clinical practice, we need to think globally in terms of the depressive episode, depressive disorder, and so on, and you need to anticipate failure. Okay, so we've been through that. Now, another concept before I move on to discussing some of the individual treatments that's come out recently is difficult to treat depression. And this has been published again by John Rush as a reconceptualization of TRD. So the DTD, or difficult to treat depression, recognizes both acute and long-term outcomes, has the issue of chronicity embedded in it, where TRD focuses only on failed acute phase treatments. So if we do a compare and contrast, we see that TRD is in opposition to, whereas difficult to treat depression is more collaborative, TRD is more acute, DTD is more chronic. The approach is mainly biological or medical for TRD, but difficult to treat depression includes biopsychosocial capability approach, recovery, movement, and so on. And DTD is more dimensional as opposed to the categorical approach that's simply inherent in TRD. And here's a schematic from Rush's paper, and I think DTD is very complementary. I think TRD is something that we might use in research, But the concept of DTD is aimed at optimizing disease management in terms of symptom control, daily function, and quality of life, rather than simply persisting in more treatment help steps in hope of achieving a sustained remission. What do you do? Well, you confirm a psychiatric diagnosis, you assess adequacy of prior treatment, you confirm adherence to prior treatment recommendations. We are working on the role of pharmacogenetics in a European-wide consortium. I think at the moment this is a very limited view, but it may be more in the future. We assess concurrent psychiatric conditions that require remediation, particularly things like substance abuse and alcohol problems. We assess general medical conditions, undiagnosed general conditions, and environmental stressors. And of course, DTD has realistic goals to help patients accept the reality of their condition, focus on achieving less symptoms, more quality of life, better psychosocial functioning, and compliance with treatment. So it's an emphasis away from being solely focused on the medication. But for TRD, we aim for sustained asymptomatic state with minimal interference in the patient's life. Now, as I've said, in terms of TRD, if you go through the first 2 lines of treatment, about 1/3 of patients develop treatment-resistant depression. This is really a shockingly large number of patients. I'll come back to that when I talk about our mood disorders treatment pathway. Now, a very, very important point that clinicians should take into account with every interaction with a patient about treatment is patient preference. This is work from George Papakostas and Coxis, you can see at the bottom there. And this is key for clinical psychopharmacology, that patients who prefer medication tend to do better in medication, and patients who state a preference for psychotherapy tend to do better in both, and the combination tends to, in general, act for both groups. So you can see if you prefer medication, you do better on that to the combination. The biggest difference is if you prefer psychotherapy, you do very well in that, but you don't do well in medication, and you don't actually do as well on the combination. Combination does better, and in both an explicit preference for combination, and also if there's no particular preference. So I think this should be something that's examined with the patient in every interaction about medication. So what do we do for TRD if we just think about medications? Well, this is from the BAP guidelines and the other guidelines listed there. Treatment strategies for patients who have not responded to therapy with a first-line antidepressant. We optimize the current therapy to exclude pseudo-resistance. Professor Erickson may talk about increasing the dose with SSRIs, which for some of them is reasonable. Augmentation with another agent, such as lithium or an atypical antipsychotic. Combination therapy with another antidepressant. Really, the only evidence-based combination is a drug like mirtazapine with a reuptake blocker. I've talked about dose escalation, and then switching to another antidepressant monotherapy. Although these strategies are common in clinical practice, the evidence supporting their efficacy is limited. So here's a recommended treatment algorithm for TRD, which goes through some of the steps that I've just mentioned. Firstly, optimization of the current antidepressant treatment and exclusion of pseudo-resistance. So sufficient treatment duration. Generally, we will get a very good idea whether the patient is going to respond to the medication by about 2 to 4 weeks. If they haven't shown at least a 20% improvement in depression scores by that period, they only have an 8% chance of showing a response thereafter. So we actually leave patients on drugs for too long before assessing them. Elias might talk about the daily doses. Some antidepressants aren't given subtherapeutically, but some are, and even some SSRIs may need to be increased. And therapeutic drug monitoring may have a place, especially when looking at the metabolic enzymes. Treatment adherence should be evaluated, as should adverse events and the effects of comorbidities and psychosocial stress. And then augmentation comes in. We've got a big trial, myself and Professor Tony Clear, where we're looking at augmenting with quetiapine, or lithium. The evidence base for this so far isn't great, actually, and the only large study was sponsored by the maker of quetiapine. Many of our patients have already been treated with combination treatment by general practitioners in the UK. So this is, for example, SSRIs with mirtazapine, and by the time they get to us, they've usually had that, and then dose escalation and switching. Now, there are other unmet needs in TRD, lack of biomarkers. We can't really say who's got TRD apart from clinical assessment, lack of recognition of risk factors, and the lack of effective treatments. And because of the pressure of time, I'm going to just focus on treatments. So the clinical psychopharmacology over the last 50 years has really been very focused on serotonin, dopamine, and norepinephrine, but we're moving to much more of a focus on glutamate and GABA, and things like NMDA receptor antagonists and AMPA enhancers, NMDA NR2B receptor antagonists, muscarinic antagonists, and vasopressin antagonists are all currently being researched. But this is the treatment which is currently available as a licensed treatment. Of course, there is the option of infusions of the racemic mixture of ketamine. These are the studies from the drug company Janssen looking at intranasal S-ketamine. And this was a novel NMDA receptor antagonist. It's now, was in phase 3 when I made this slide, but it's now fully licensed in North America and Europe. And you can see that compared to placebo drug, both were given a novel antidepressant. There's a sharp improvement and a significant extra benefit at 28 days. And this again is the different studies with the intranasal S-ketamine, which we are certainly using in trials, and we think is probably something that sits fairly early in the treatment pathway. Now, in terms of the long-term sustained effect, Janssen, I think in response to requirements from the regulatory authorities, had to look at the sustainability of the antidepressant effect, and you can see in both SUSTAIN 1 and SUSTAIN 2 that after the individual responded, there really was a good likelihood of continuing to show benefit from continued administration. The key question here is how long the treatment will need to go on for. Some patients will be able to discontinue reasonably early, but some may need more prolonged treatment. I think that's still open to some degree of question. What about non-pharmacological treatments for patients with TRD? Well, psychotherapy. Studies have shown that psychotherapy, particularly CBT, is effective when combined with antidepressant treatment. So I think this should come in reasonably early in our treatment algorithm, our treatment pathway. CBT, of course, isn't available everywhere, but is now available on internet forms, E or iCBT, and this may improve the scalability and reach for delivery of this treatment. What about non-pharmacological treatments, neurostimulation? Well, still the best is ECT. We did a recent systematic review published in the British Medical Journal just before COVID, and this found that bilateral ECT was the most effective. Transcranial magnetic stimulation is antidepressant, but to my knowledge doesn't have the same efficacy in treatment-resistant depression as ECT, although there are a couple of intriguing early studies where TMS has been combined with ECT on different days. So on the days when you don't get ECT, you get TMS, and these small studies suggest extra benefit. Vagus nerve stimulation, which is widely used for epilepsy. This is approved for TRD, and the long-term studies are needed, but the case register studies do show long-term benefits. And I think this really is much more of a long-term treatment that will benefit some patients very greatly. And of course, there's other new neurostimulation treatments in development, like magnetic seizure therapy. So this is our Maudsley treatment pathway. So we say for people with depression, we say, first of all, we need to screen for depression and diagnose. In developed market economies like Western Europe, only 25% of people with depression get even minimally active treatment. And in lower income countries, this is as low as 4%. Thereafter, The first treatment is usually going to be an antidepressant, an SSRI or an SNRI, although of course psychotherapy, if it's a preference and it's available, can be given at this stage. Then, if an inadequate response, you think about switching within the same or to a different class. You think about combining psychotherapy or antidepressants together, particularly mirtazapine. Or you think about augmenting with atypical antipsychotics, lithium, thyroid, or indeed S-ketamine. And this I haven't put as a linear response because I think it's clinical judgment and patient preference as to what is given next. For an inadequate response, ECT, VNS in particular, although in some cases ECT may be given at the beginning. You should maintain treatment for 6 to 9 months for first episode or at least 2 years if at risk of from my colleague in London, Professor Glyn Lewis, which he came and discussed with us yesterday in our journal club, showing that his New England Journal of Medicine with antidepressants for more than 2 years. So to summarize, and my profuse apologies for my slide issues, the development of TRD is impacted substantially by factors such as comorbidities and early life experiences. For most patients, the important remission factor is the presence of positive mental health. Treatment effectiveness importantly relies on patient treatment preference. Current unmet needs in TRD include the identification of biomarkers, risk factors, outcome predictors, as well as fast-acting efficacious treatments. Several treatment strategies for TRD are currently in play everywhere: augmentation, combination, dose escalation, and switching. I think John Rush's new reformulation, difficult to treat depression, is not going to influence regulatory authorities, but for clinicians, it's an interesting and potentially helpful way of considering these issues. And lastly, novel therapies are in various stages of development, not only the glutamatergic system, but remember, as I'm sure Professor Erickson will agree, glutamate and GABA are very, very interlinked, and these are both potential ways of developing future therapies, and indeed, these are being developed at present. Here are some references, and I'll stop there, and thank you for your attention. Thank you very much.
Well, thank you for your comprehensive presentation, Professor Yang. I think we still have 5 minutes for questions. Is there any question from the audience? İzleyicilerden sorusu olan var mı? Maybe I can ask a question for you to inducing the discussion. So you emphasized the esketamine for intranasal esketamine for treatment-resistant depression. And is there any information about the manic switch rates for these esketamine studies? Because you know, considering the follow-up studies indicate that more than 20% of the treatment-resistant patients are diagnosed with bipolar disorder in the future. So, and also I'd like to ask what do you think about the addiction risk for this intranasal ketamine?
Thank you. Those are 2 great questions. So the first thing to say is that there's a belief, for example, the great Professor Angst from Zurich believes that manic switch rate is very much linked to the potency of being an antidepressant. So therefore, you might expect ketamine or S-ketamine to have a higher manic switch rate. In the S-ketamine trials, the manic switch rate was extremely low. In fact, I've not actually been able to find any reports of it. I've also talked to Carlos Zarate about his experience of giving the infusion, and we've given the infusion as well, and we haven't really seen any manic switch, which is actually quite surprising because you would expect to see this spontaneously. So there is the possibility that ketamine is actually anti-manic, which would be very interesting. We're currently reviewing the literature. We're looking at all of the infusion and clinical trial data. But at the moment, our preliminary indication is there doesn't seem to be a signal of manic switch. And if there is, it's certainly not excessive. And you're absolutely right. I mean, the studies suggest that up to 25% of people with treatment-resistant depression will be unveiled as being bipolar within 5 years of diagnosis of TRD. Second point is about addictions. Now, the ketamine is, of course, abused. There was a move at the WHO to ban ketamine internationally, but of course it's a very useful drug for veterinary and for field anesthesia. But that's because in some parts of the world there's very high rates of abuse. It's a party drug in the UK. People take it at raves, they take it for the dissociative side effects. They dose escalate and they get very, very severe ketamine-induced urinary tract toxicity, which is of great concern. So this was in the S-ketamine nasal regulatory trial, something that was looked at very carefully. And so far, there's no signal of any concern. Now, this may be a dosing effect, but it certainly seems to be okay in terms of the urinary tract toxicity. There does remain an issue about abuse. And I think that's one of the reasons for giving ketamine infusions and nasal ketamine in a hospital setting. I would be much more worried about giving people ketamine to go home with. I think if there's a history of drug abuse, you've got to be very careful about giving the patient ketamine. But remember, what happens now is the patient comes into the hospital once or twice a week, gets given the ketamine. Going to happen.
Thank you. I think we should skip to the second presentation.
Okay, thank you very much. Sorry about my slides. I do apologize.
Thank you, Dr. Young. Hello, Dr. Erickson. It's a pleasure.
Hello.
It's a pleasure to be with you for this conference. First, I would like to present you to the audience, and then you will start. Dr. Erickson, Göteborg Üniversitesi'nde Institute of Neuroscience and Fizyoloji ve Neuroscience Enstitüsü'nde kendisi psikofarmakoloji alanında çalışıyor. Orada yine farmakoloji bölümünde çalışmakta, öğretim üyesi olarak. Bugünkü konusu Mechanism of Action of SSRIs in Different Conditions. Farklı durumlarda SSRI'ların etki düzenini anlatacak. Please, Dr. Erickson.
Okay, thank you very much. It's nice to be given the opportunity to give this presentation. I, in fact, also had some problems with my slides, but now they seem to work nicely. I hope you can see the first one. I will tomorrow. A starting point for this presentation is that I do believe that the SSRIs are effective, and I will give another lecture tomorrow where I will address this issue more in detail. So today I would like to just give some speculations regarding the mechanism of action of these drugs, and this will be to a great extent based on some work we have done throughout the past decades and work done by many others, just to shed some light on why do these drugs act in depression and in other conditions. And first I would like to just give a brief crash course regarding the history of the reuptake inhibition in depression. That all started in December 1950 when at Rouen-Poulin, Paul Charpentier and Simon Courvoisier synthesized a novel antihistamine, chlorpromazine. And that, of course, they handed over to a surgeon, Henri Laborie, who showed this drug to be, he used it, tested it as pre-medication prior to surgery, and he suggested that this had some unusual mental effects, so it should be tested in psychiatry, he thought. And that, of course, was the starting point for modern psychiatry and modern psychopharmacology, when Delay and Denicare, as you all know, showed chlorpromazine to be effective for schizophrenia in 1952. At that time, shortly thereafter, Geigy, a Swiss company, wanted to develop their own antipsychotic drug, anti-schizophrenic drugs. They made some minor changes to the chlorpromazine molecule and developed imipramine. And then it was tested by the Swiss psychiatrist Kuhn, and he reported that this unfortunately was not antipsychotic, but it was markedly antidepressant, one of all these serendipity findings that have been so important for psychiatry. I could just add here the schizophrenia field was fortunate for the antidepressant field, then in fact the depression field paid back, because later on imipramine was modulated to form clozapine, that was also meant to be an antidepressant, but was shown, as you know, to be the most effective antipsychotic drug. So they are quite similar, these drugs, from different classes. Okay, so at this time no one knew, when this was introduced, the tricyclic antidepressants, after the observation by Kuhn, no one knew how they exerted their action. Then Julius Axelrod, subsequently Nobel laureate, in 1962 he showed that these drugs, imipramine particularly, block, as you know, the reuptake inhibition of noradrenaline. So we have more noradrenaline extracellularly in the synapse. And then Schildkraut, in a very extensively cited paper, suggested that depression may be due to noradrenaline deficiency. This was back in the years when we knew very little about brain neurotransmission. The transmitters named by Alan here, GABA and glutamate, were still unknown as neurotransmitters. So in fact this was a very early hypothesis in relation to what we in fact knew about brain function in those days. Then a few years later, 1968, Arvid Carlsson in Gothenburg, pharmacologist, showed that, well, in fact, both imipramine and other tricyclics also block the reuptake of serotonin. So serotonin might be just as important for depression as is noradrenaline. And he also showed that clomipramine, one of the drugs that he tested, one of the tricyclics, had a much more robust effect on serotonin than the other ones. Low figure here means that you have a strong serotonin reuptake inhibiting effect. So here we had at these days a European school of thought suggesting serotonin to be important for depression. Advocates for that was also Herman van Braak from the Netherlands and Alec Coppen from UK, and some other psychiatrists and pharmacologists. And then we had the American school that noradrenaline was the important transmitter here. Arvid realized that to solve this problem, because all tricyclics impacted both serotonin and noradrenaline, Arvid turned to Astra, this was before it was AstraZeneca, and suggested that they in collaboration should develop a selective serotonin reuptake inhibitor to see if that was antidepressant. And in 1972 they developed the first of the SSRIs. It was called cimelidin, and it indeed was shown to produce a robust antidepressant effect, but it was later unfortunately withdrawn due to side effects. And then of course followed all the SSRIs, with Prozac as most well-known example, and they rapidly became first line of treatment for depression. So in those days we had this quite simplistic serotonin hypothesis of depression as an alternative to the noradrenaline hypothesis of depression, but stating that maybe we have a lack of serotonin or underfunction of serotonin in depression. And the support you have heard before, old traditional support for this hypothesis, is that antidepressants, the reuptake inhibitors, enhance extracellular serotonin levels and are antidepressant. MAO inhibitors also enhance extracellular serotonin levels and are antidepressant. There were some studies suggesting that serotonin precursors such as tryptophan and 5-hydroxytryptamine could be antidepressants. Reserpine was known to deplete brain serotonin and could elicit depression. Then of course reserpine also depletes dopamine and noradrenaline, and of course those actions could also contribute to this effect, but that was part of the reasoning. By the way, reserpine has not been used for many decades, but as you may know, now they treat Huntington's disease with the reserpine-like drug, also depleting brain monoamines by inhibiting the storage into vesicles, and that drug indeed also can cause depression as side effect. So this kind of side effect has been confirmed in that way. And then there were some American studies by Shopsin showing that if he arrests tested the synthesis of serotonin with the synthesis inhibitor, PCPA, in patients that had responded to antidepressant, then he could produce a relapse. So this was kind of the basis for the traditional theory. That was kind of simplistic, sometimes in advertisement illustrated in this way, that depression is simply a matter of lack of serotonin. And of course, people in the field have never regarded it as this simple, but still there are indeed strong reasons to believe that in one way or another serotonin is involved. Sometimes it is argued by the anti-pharma camp that this theory is obsolete and has been proven wrong, and that is obviously not the case. Serotonin indeed seems to be involved, and there are studies that I won't have time to go into here, but studies where serotonin function has been measured in patients, suggesting that there are interesting abnormalities, however, in depressed patients and in anxiety. However, they have not provided a definite answer to the question, do we have a aberration in patients as compared to controls, and if so, in what direction and what brain region? Still, this is kind of unclear, one must admit. I would like to give some comments on this discussion by discussing two disorders that we throughout the decades have been particularly interested in, accidentally more or less, but then we have worked a lot on these disorders, and I think they may shed some light on the mechanism of action of the serotonergic drugs. First, I would like to say that, as you all know, shortly after the SSRIs were introduced, and even before that, using clomipramine, the tricyclic, with the shown by Arvid to have a very marked effect on serotonin, in being a forerunner of the SSRIs, one could say. All of these drugs, of course, are very effective, not only for depression, but also for a number of other conditions. And for some of these conditions, they have a considerably higher effect size than for depression. For example, I would say this is true both for panic, where most patients can get rid of the panic attacks with an SSRI or clomipramine, and not least premenstrual dysphoric disorder, where we have effect sizes way above 1, which is very high indeed. And I have always thought that when you discuss the mechanism of action of SSRIs, you shouldn't just focus on depression. In preclinical work on these drugs, they are often discussed from the perspective of depression, but to understand how they work, you should probably also contemplate over their marked efficacy in other conditions. Why are one group of drugs effective for so many quite disparate psychiatric disorders? And so we have been particularly interested in panic and premenstrual dysphoria, and I will just give a few comments about panic. This is Donald Klein, the legendary American psychiatrist who passed away a few years ago, who already in 1962 reported, together with Max Finks, that panic attacks may be reduced with the tricyclic antidepressant imipramine. There was not a big fuss about this finding. It didn't make any major splash initially. It was not until many years later, when panic appeared in the DSM, that this observation really was taken into consideration. And then, of course, there were a number of studies confirming that imipramine was an effective anti-panic drug. And in those days, most people believed, it was a very popular theory this time, that panic is associated with an increased activity of brain noradrenaline neurons emanating in the locus cerebellus. That was regarded as a kind of anxiety center in brain, which and then it was since tricyclics may, by a feedback mechanism, reduce the firing of noradrenaline neurons. This was assumed to be the mechanism of action of imipramine, to reduce the noradrenaline activity. This is a bit paradoxical. When the same drug was used in depression, it was assumed to augment noradrenaline transmission. When it was used in panic, it was assumed to dampen noradrenaline transmission. However, I have had a colleague, Kjell Modig, who was both pharmacologist but also psychiatrist, and he read the Klein paper quite early, and he started to use imipramine and was quite impressed that this did in fact dampen panic anxiety. But then, since there were some studies that in OCD, obsessive compulsive disorder, clomipramine was better than imipramine, much better. He tried in his clinical work clomipramine, anafranil, in Sweden, and found that that in fact seemed much superior to imipramine in the treatment of panic. This was before the introduction of the SSRI, shortly before I should say, at about the same time, but shortly before. So we did a comparative trial and could indeed confirm that imipramine was better than placebo, but clomipramine was even better. And as you can see to the left here, in fact, we had no dropouts here in this study, and we had 0 panic attacks at the end. I should say, I can come back to that, that they were allowed some benzos in the initially, but I will come back to that. But as you can see, it's a very dramatic effect, and we did find that clomipramine was better, and this has been then confirmed in many, in several, I should say, not many, but some later studies. And also, it was a very early study from the Netherlands showing that one of the SSRIs, fluvoxamine, was better than a NA reuptake inhibitor, meprotolin. And then later, of course, all of the SSRIs were shown to be effective in panic, but selective noradrenaline reuptake inhibitors do not seem effective. So taken together, it is probably not noradrenaline that is the key transmitter when treating panic. It seems to be serotonin. So from our experience with clomipramine in panic in these days, we learned several things. And one was that it is really an excellent efficacy. It's with clomipramine, a high potency, we could often use doses as low as 25 milligram per day or so, which indicates really that this was an SSRI effect. At those dosages, clomipramine is very similar to an SSRI. We showed that this was clomipramine was better than less serotonergic antidepressants, and we also showed that you can see here that it's a very sluggish response. So you have a continuous improvement 12 weeks after the initiation of treatment. And then we also noted that it was a very high prevalence of initial aggravation of anxiety. Almost all panic patients, when they received clomipramine, displayed enhanced anxiety for the first days or week of treatment. So in clinical work, we used tiny doses, lower than 10, to start the treatment. And we often, and in the clinical trial, just to avoid lot of dropouts, we allowed benzos for the first days or weeks of treatment to make the subjects stay in the trial. We found this quite interesting. Why do this drug, and also later shown for the SSRIs, why do they cause anxiety especially in panic patients? This phenomenon has been described, of course, by others. Sinclair and co-workers from UK, antidepressant-induced jitteriness anxiety syndrome, and others as well. So this is, from a theoretical point of view, if serotonin is a beneficial, so to say, for anxiety and depression, we want to increase serotonin. Why do we initially have enhanced anxiety in these patients? There are 2 other drugs, fenfluramine and MCPP, and they cause an even greater increase in serotonin in the synaptic cleft. They don't just block the transporter, they reverse the direction of the transporter, so you get a release of serotonin into the synaptic cleft, and that is acutely a more forceful serotonin augmentation than with the reuptake inhibitors. So how do these drugs impact anxiety in panic patients? Well, in fact, both MCPP, as in this study, for example, and fenfluramine, this is another MCPP study, and also fenfluramine, sorry, I missed the fenfluramine, yeah, here it is, also fenfluramine. Both these drugs may cause anxiety in panic patients, which is very much in line with the initial serotonin SSRI-induced augmentation of anxiety. So if you enhance serotonergic output acutely, these patients respond with enhanced anxiety. We wanted a few years ago to see how common is this phenomenon in other disorders. It is not unheard of in depression as well. And indeed, it's much less common in depression, but you do see it in depression as well. Here, you can see that already after 1 week of treatment, we have in fact a beneficial effect of the SSRIs in terms of psychomotor agitation and in terms of, I should say that this is a post hoc analysis on patient level of a very large number of SSRI versus placebo studies with paroxetine, sertraline, and citalopram. And I will talk more about this work tomorrow, in fact, at this Congress. But as you can see, we have already after 1 week a better outcome with the active drug with respect to psychomotor agitation and psych anxiety, but we do have a subtle aggravation of somatic anxiety first week in the Hamilton scale, which then fades away. And when we look on anxiety-related adverse events, we have indeed a tendency for more anxiety side effects reported with SSRIs initially, and also nervousness, and this is a significant effect. So there is indeed also in depressed patients, some that respond with increased anxiety. And there are in fact also studies suggesting that SSRIs may be in some way anxiety provoking also in healthy volunteers. So generally it seems as if acute serotonin facilitation enhances anxiety. So my questions here would be, why does clomipramine and SSRIs sometimes in susceptible individuals at acute administration enhance anxiety? And why does the beneficial effect of clomipramine and SSRIs require many weeks of treatment to be fully developed? This is, of course, the question that has been asked for decades with respect to the antidepressant effect, but that is quite as relevant with respect to the anti-anxiety effect. And why does tryptophan depletion, where you can arrest serotonergic transmission, do not aggravate anxiety? This has been tested, and there are no robust effects of tryptophan depletion in terms of increasing anxiety. Okay, I would now like to leave panic disorder for a while and go to premenstrual dysphoric disorder, which is in fact a fascinating, intriguing condition. Sometimes it's argued that this is invented by the drug companies to sell SSRIs, but that is clearly not true. This was described by Hippocrates, by Trotula de Salerno in the 11th century, and Ernst von Feuchtersleben in 1847 gave a quite adequate description. The menses in sensitive women, or rather the week before the menses, is almost always attended by mental uneasiness, irritability, and sadness. And subsequent studies have shown that irritability is indeed the core symptom here. It's not sadness, it's not uneasiness. Irritability or anger is by the patients themselves reported as the definitely most prominent symptoms. This is a typical from one of our studies. You will see the rest of this slide later on, because after 2 cycles these women will have a treatment, but I will come back to that. Here you can see the typical cyclicity in the symptoms. These women have, in a clinical trial, have been asked to rate their premenstrual irritability 0 to 100, and here you can clearly realize where the menses were. They were here and they were here. So there is a sharp increase in symptoms the week before menstruation, sometimes 2 weeks, sometimes just 3-4 days, and they are totally symptom-free in the follicular phase, which is fascinating. And of course this is related to sexual steroid. It's known that if you arrest the release of sexual steroids, you also get a relief of premenstrual complaints. So it has something to do with how the sex steroids impact the brain. And of course there are multiple evidence that sex steroids do impact the brain. I will come back to that briefly later. The reason why we became interested in this condition is that we, many years ago, together with Arvid Carlson, studied sex differences in brain serotonin, and so we were in general interested in this impact of sex steroids on the brain. And then we were approached by a gynecologist in Gothenburg, and he had been studying premenstrual disorder, and he was a bit premenstrual syndrome that it was called in those days, and he was a bit frustrated that there were no effective treatment. So he came to us and said, I have realized that this is not mainly a gynecological disorder, it's a psychiatric disorder, and couldn't we try some psychoactive drug? And much to our surprise, because I was not aware of the field, serotonin uptake inhibitors had never been tested, probably because this had not been studied by psychiatrists but only by gynecologists. They had tried hormones and vitamins and natural products and stuff like that, but not serotonin reuptake inhibitors. So we tested in a small open study clomipramine, again the same drug as we used in panic, one trick pony, and we always use clomipramine in those days, and as you can see here, we did see a very marked reduction in premenstrual irritability, self-rated. These subjects had in fact been participating in another control trial we had done prior to this, which was not a success, and they had not responded well to placebo. So we really believe this was an actual effect. And then we could confirm this is in a control trials. But in both these studies, we gave it continuously, because this is how this drug is, of course, used in anxiety and depression. And since there is normally a delay in the response, one should expect that you need to give this continuously to have a beneficial effect. But then some of the patients told us, asked us, why should we take this drug all month when it has side effects? We get dry mouth and so on, and we don't have symptoms more than a few weeks, so why should we? Well, you cannot take it intermittently, we said, because it has a long time between the onset of treatment and a beneficial effect, a delay in the response, so you have to take it continuously. But then some of them phoned back and told us, well, you were wrong, I tested and it worked nicely to just take it during the symptomatic days. So we did a very small, that is why we didn't reach significant in the second cycle, a very small pilot study where we used intermittent administration, just giving this in the premenstrual phase, and indeed it worked very nicely. And this is the rest of this figure. This is a study. We have done many studies with in PMDD with different SSRIs, and I won't go into most of them. But here you can see the continuation of this study. This was what I showed before treatment, and this is with placebo, and this is with intermittent citalopram. So you can see this is these are medians, so this is obviously an effective treatment, also when given intermittently. Now, in fact, escitalopram is I think Sweden is one of the few countries in Europe where there is an SSRI approved for PMDD, and that is escitalopram. And we did, in fact, the only study with this drug, placebo control, that formed the basis of this approval. And normally the authorities require 2 trials, but I think it was our quite impressive p-value that made the trick here. It was not a very big study, but still it was extremely significant. We have always effect sizes about 1.5 or so for the effect of these drugs on premenstrual irritability. So that makes this an interesting condition. Why do they respond so robustly to these drugs? We also wanted to study how fast this is onset, really. So here we started treatment in the midst of the luteal cycle when the irritability was pronounced. And then you can see here 2 hours, 4 hours, 8 hours, it starts to separate already at day 1. And at day 3, we have a clear-cut separation between active drug and placebo. And the reason why we don't have the similar effect day 1 is probably pharmacokinetics, because these are the serum levels of paroxetine. So it takes a few days to build up reasonable levels. So this is almost an immediate effect, very unlike then the effect in depression and in anxiety. So if this is the case, then those drugs that I mentioned before that do cause a robust acute increase in serotonin extracellularly, that is fenfluramine and MCPP, then they should have a beneficial effect here. And in fact, they have. There are studies showing both that MCPP reduce symptoms of irritability and other symptoms of PMS, and also fenfluramine shown by the Wortmann group many years ago. So here we have quite a different situation as compared to panic. Here we have beneficial acute effects both of SSRIs and of the releasing drugs, fenfluramine and MCPP. I should also say that I said that the main prominent symptoms in PMDS is anger and irritability, and this is not this effect of SSRIs is not unique for that disorder. There is in fact reported a reduced anger and aggression also in patients, for example, with dementia, brain injury, stroke, and autism. And interestingly, this effect also seems to appear shortly after the onset of treatment. So when it comes to effects on anger and aggression, irritability, these drugs seems to have a very short onset of action. So why does clomipramine and SSRI exert a marked symptom reduction in premenstrual dysphoria almost immediately after the onset of treatment? And why does acute administration of fenfluramine aggravate anxiety in patients with panic but reduce symptoms in women with premenstrual dysphoria? Then I would like to summarize what is known about the other acute effects of SSRIs in humans. As I mentioned, they do reduce anger and aggression. That is then shown in several conditions. They also have an acute effect on sexual function. You know, impaired sexual function, reduced libido, delayed or impaired orgasm are common side effects of SSRIs, and this has also been used as a therapeutic possibility to treat premature ejaculation. And what is interestingly here is that this effect is also immediate in onset. So this has been used as an on-demand treatment, that is to take, say, 30 minutes or so before planned sexual activities. And so also the sexual side effects seem to appear very rapidly after acute administration. Then, as you all know, these drugs may cause nausea, and early on during treatment, the first week or weeks, that is a common side effect, and it has been shown in studies that you have a reduction in weight often with SSRIs, at least during the first weeks of treatment. And as I mentioned when I talked about panic and anxiety, we have in some patients an increase in anxiety. So now I would just spend a few minutes on rats. If you go to the animal kingdom, which are the dominating physiological effects of brain serotonin transmission? Of course, thousands and thousands of papers have been published on serotonin and behavior throughout the decades, and I won't go into any detail here, but which are the dominating physiological effect of this transmitter? And this has been studied. This is most effectively studied by taking away the transmitter and see what happens, and this could be done with serotonin synthesis inhibitors such as the good old PCPA. There are also neurotoxins, there are lesions of the RAFE nuclei that will deplete serotonin, and you can knock out, for example, the serotonin synthesizing enzyme tryptophan hydroxylase in mice, and then you have a depletion of serotonin. And these different techniques, by and large, not exactly, but by and large, provide the same answer, that one very pronounced effect of serotonin seems to be to dampen aggression and anger. So serotonin depleted rats or mice become more aggressive, and this is something that has been shown in a lot of vertebrates, a very conserved role of serotonin, and it may even be present in invertebrates, but a very conserved role of serotonin in vertebrates is to dampen aggression. So this has been known for a long time. Another effect of depleting serotonin is enhanced sexual activity, already shown many decades ago by Gigi Gessa in Italy, and also more recently Nature shown using molecular modulation of serotonin transmission. So another important role of serotonin seems to be to reduce sexual drive. If you take away serotonin, you have a enhanced sexual activity. Then we have it's shown since long ago that if you give SSRIs, rats eat less. It has a appetite reducing effect. In fact, when Lilly once developed Prozac, first they planned to use it as a drug for obesity, an appetite reducer, but then they realized it was antidepressant. And finally, it's known also from many animal models of anxiety that SSRIs, that serotonin seems to enhance anxiety. If you take away serotonin with PCPA, of course, for example, in various animal models of anxiety, they behave as if they had received Valium, benzodiazepine. They are less anxious, and if serotonin is augmented, they often display enhanced anxiety. So an overall function of brain serotonergic transmission may be to in an evolutionary perspective, to redirect activities from such as aggression, sex and food intake to fear and flight in situation of threats. That would fit all these effects, make them fit nicely together. That this is something that serotonin is something that should impact your how inclined you are to redirect your activity from aggression, for example, towards another male for competition for a female or for getting food or something like that, sex and food intake, and instead how prone you are to react on fearful stimuli. So yeah, I think I will skip this slide. I will just say that sex steroids here come into play a lot because there are, as I said before, a lot of data suggesting that sex steroids impact serotonin transmission, and also that we have this sex difference in serotonin activity. But I think I will skip this. In fact, I could just say that we do see differences between males and females in anxiety-related behavior, and that we can, if we deplete serotonin, the differences disappear. So, and we have seen that in different models here. So it seems that serotonin is important to uphold various sex differences. But I will skip that, and because we are somewhat late here. So to summarize, the dominating behavioral effects of serotonin, as judged by old and more recent animal studies, is to reduce anger aggression, to impair sexual function, to reduce food intake, and to enhance anxiety. Then, if SSRIs indeed increase serotonin, we know that if you use microdialysis in animals, we know that SSRIs do increase extracellular serotonin. But then they should, of course, preferably have the similar effects here. They should augment these behaviors, and they in fact do. For example, we do see reduced anger aggression in animals with SSRIs. This is, for example, our little animal model of premenstrual dysphoria. This is just to show how female rats, dependence of cyclicity on aggression in female rats, and then how this can be treated with an SSRI, reducing the cycle-related aggression. And there are also numerous other papers by others showing that SSRIs may reduce both anger and aggression in both male and female animals. We also have impaired sexual function with SSRIs. These are two studies from our group in both male and female rats, just as in, and that this has been shown also by others. We do have a reduced food intake, and we have enhanced anxiety. So, in fact, as judged by animal experiments, SSRIs do indeed increase serotonin transmission at acute administration. Is this relevant also for humans? Well, sorry, this is just an animal study from us before. I show the next one. This is the so-called X-maze, and here you can address the anxiety of the animals. How much do they enter the open arms and how much do they keep hidden in the closed arms? And what we show here is that, I won't go into detail, but rats that are more anxious, they have more serotonergic activity. If you take away serotonin, you abolish the difference between anxious and non-anxious rats. If you give paroxetine, you have an enhanced anxiety in the anxiety-prone animals, very much suggesting that serotonin promotes anxiety and that SSRIs can augment anxiety. And we have also shown similar with the startle paradigm in rats. So this was just to support that we may enhance anxiety with SSRIs. And what about humans then? Well, I showed you this before. This is exactly what we see in humans also. So what I would conclude here is that the effects sometimes or consistently observed after acute administration of SSRIs to man correspond perfectly to the acute effects elicited by the same compounds in rodents and are generally opposite to the effects observed after serotonin depletion in rodents. So that is fine, but if serotonin then is anxiety provoking also in man, are the anxiety reducing effects observed upon long-term administration of SSRIs, how should we explain them? May then be the result in fact of a compensatory downregulation of an anxiogenic serotonergic influence rather than an augmentation of serotonin as was recently believed, or previously believed, I mean. This is just to, I think we can skip this is just to show that SSRIs in our hands do downregulate the serotonin synthesis enzyme. This we can skip also. This is the study, in fact, supporting that we may have increased serotonin activity in anxiety. This is in panic disorder, and here they have measured serotonin levels in the jugular blood flow. It's quite a original and unusual way of assessing brain serotonin transmission that might have some value, and they showed here increased serotonin turnover in panic patients. They also showed the same in depression, and they then show in both conditions that SSRIs reduce the outflow. And this is a recent PET study from Sweden suggesting that serotonin is indeed enhanced also in social anxiety disorder. So there are indeed some support for the notion that serotonin should by and large be regulated by, be regarded as an anxiety-provoking transmitter, and then perhaps SSRIs, the effect of SSRIs mainly is to dampen such an impact. However, it could also be that we have a dual influence, that in some brain areas we have a augmentation of anxiety by serotonin, in other areas the opposite, and I won't go into details here, but there are, for example, indications that in some of these areas serotonin anxiety provoking, but in, for example, PAG it may be serotonin dampening. And then of course we have all these serotonin receptor subtypes, 14 or 15, and of course one could speculate that some of them are anxiogenic or some of them are anxiety dampening. Finally, I would like to spend a few words about the topic that Alan so brilliantly gave a review of in his presentation, that is difficult to treat depression. And firstly, if there should be differences in efficacy between various antidepressants, if you should believe in this meta-analysis in Lancet by Cipriani, the only really superior drug would be amitriptyline. We believe that this superiority to some extent is due to the sedative effect of amitriptyline that will give a lot of extra points on the sleep items in the Hamilton scale. But we have also some indications that there is in fact an actual superiority of amitriptyline to treat depression. Needless to say, amitriptyline has a lot of disadvantages in terms of toxicity in overdose and side effects and so on. But from a theoretical pharmacological point of view, it would be important to clarify why amitriptyline seems somewhat more effective also with respect to antidepressant properties, not only with respect to sedation. And these are some of the possible mechanisms that could be a contribution to this. Maybe H1 antagonism, antihistamine, I don't think so. Maybe the noradrenaline reuptake inhibition is to some extent antidepressant. Selective NA reuptake inhibitors are not that effective in depression, but maybe this could contribute. Muscarinic receptor antagonists could in fact have some antidepressant properties, but also I would like to emphasize here that this is an antagonist on a certain serotonin receptor, that is a 2A receptor. Then we have, as mentioned by Alan, the possibility of adding another antidepressant. And a very popular alternative, at least in Sweden, is to add mirtazapine. And there are these nice studies by Pierre Blier suggesting that mirtazapine may indeed augment the effect of reuptake inhibitors. Then other studies have been this was negative, this study from US, but we also have this study from UK that first seemed negative, but then when they looked on anxious patients, they had a clear-cut augmentation with mirtazapine. So I would suggest that at least in a subgroup of patients, mirtazapine may indeed augment the effect of SSRIs. And then what could be the mechanism behind this effect? Well, it's a H1 antagonist, it's an alpha-2 antagonist, but it's also a 5H2 antagonist. Then we have, as also mentioned by Alan, the effect of adding an atypical antipsychotic drug to SSRIs. That is well documented that this has a beneficial effect in treatment of depression, not responding to SSRI alone. And all of these are in fact, apart from their effect on dopamine receptors, they are also 5H2A antagonists. There are some studies from United States, interesting, I think, from Yale many years ago or some years ago, showing that adding to a antagonist or inverse agonist to an SSRI enhances the antidepressant-like behavior. They have also discussed this in a subsequent paper. And we recently demonstrated the same in an anxiety model. This is conditioned fear. And when we give a serotonin 2A antagonist, nothing happens. When we give escitalopram alone, nothing happens. But the combination causes a marked reduction in anxiety or in freezing behavior. Also, when we test pimavanserin, that is another inverse 2A antagonist that is used in the United States to treat psychosis in Parkinson patients, and we get the same, that the combination augments anxiety. And in fact, pimavanserin has been shown to augment the effect of an SSRI in depression. There is also, unfortunately, a subsequent study where they didn't reach significance on the primary effect parameters, so now they will probably not pursue this, but they did again have an effect on anxiety. So adding pimavanserin, which is very selective for the 2A receptor, seemed to do the trick in some depressed patients at least. To make this even more complicated, however, LSD and psilocybin that may, on single doses, exert antidepressant effects are 2A receptor agonists. So this is complicated. And in fact, in the same paper, we showed also psilocybin to have an anti-freezing effect, just like the combination of the antagonist and SSRI. So I don't blame you if you find this a bit confusing. It is a bit
Dr.
confusing.
Erickson,
Yeah, this is my last slide. Sorry. So, sorry, time is running out. I realize that. So my very last slide. Although serotonin reuptake inhibitors have been used for more than 70 years for the treatment of anxiety and depression, we still do not know if they promote or dampen the impact of relevant serotonergic pathways or which serotonergic receptors that mediate their effects. And it is still not unlikely that there are novel ways of modulating the activity of serotonergic synapses that will prove superior to selective reuptake inhibition for the treatment of psychiatric conditions. That is, for example, blocking various subtypes of serotonin receptors. So, though I totally agree with Alan Young that glutamate and GABA are very exciting possible targets for novel antidepressant, we should not forget about the serotonin synapse. There is still more to do in that area as well. Thank you very much.
thank you very much for your extensive review. Thank you. We have no time for the question. That's why we have end the meeting. Thank you very much.